Now's the time to finally realize we the people must make some choices. If we want single-payer health care, now's the time to raise our voices.
It's my distinct pleasure to introduce our speaker for tonight. Dr. John Scott is currently an associate professor at Harborview Medical Center. We're very fortunate to have recruited John back to Harborview. He took somewhat of a circuitous route to get here for the second time. John was born in South Carolina, is that right? That's where he grew up?
Grew up in South Carolina.
And went to this low-rent institution in Boston, Harvard University, for his undergraduate degree, where he graduated with honors while playing football and being on the track team. So he was a busy guy. After that, John went on to Vanderbilt Medical School, where he received his MD and a MPH, if I'm not mistaken, or did you get that back at Harvard?
I was back at Harvard, but yeah.
Back to Harvard and got his MPH, and then he was one of our trauma and critical care fellows at Harborview, and then took an academic position at the University of Michigan, where he spent a few years, but we were able to lure him back. Eileen Bolger, the chief at Harborview, lured him back to join our staff, where he now is not only a trauma and critical care surgeon, but John also has an appointment as an adjunct professor in the Department of Health Metrics Sciences at the Institute for Health Metrics and Evaluation at the University of Washington. John has lived and worked all over the world. He spent a year or so, at least, in Rwanda and other places in Africa, where he met up with some of our other colleagues at Harborview, Charlie Mock, Barclay Stewart, and some others, and has studied the healthcare delivery extensively in Africa as well as in the United States. And his main academic focus is using large databases to point out the inequities in medical and surgical care delivery. So, John, I'm absolutely delighted to have you join us and share your thoughts with us tonight.
Awesome. Thank you very much. I really, you did your homework. That's pretty good. So I'm grateful for that. Yeah, I'm grateful for this chance to chat with y'all and learn from y'all too. I'm going to share with you what sometimes is a research talk. Sometimes I give it to trainees that want to go into research, and it's a bit of my story and how I kind of got thinking about some questions and learned over time, and it builds on each other. And sometimes it's a quality talk when people don't want to, talk about some of these topics. We say, well, how about the things that keep your patients from having the outcomes that you want them to have? And so sometimes I pitch it as it's this insidious threat to our patients' health and well-being and long-term outcomes that we're kind of blind to. Sometimes it's a policy talk and sometimes that's policy evaluation, sometimes how you do it. But really it's about the sort of soul of our profession as physicians, as a health system, all the pieces together. And so I'll go through a bunch of studies that we've done and things I've learned along the way, but really I welcome some perspective and some insight because it's both fascinating and infuriating, and the times that we're in right now, it's never been more important, I think, to highlight some of this stuff and start working towards solutions, because I'm going to highlight a lot of problems. There can be no surprises to this crowd. But with that, I'll get started on my screen share here. And so the title is Cured into Destitution. It came from a paper, well, I'm sure it's a quote older than this, but a paper we wrote a while back of the fact that our health system's designed to spend a lot of money to save somebody's life and not at all designed to think about what are the downstream financial consequences of the care that we provide and the way we put it together. I have some funding, but it's not relevant to this. The real the topic became the question of affordability and how we pay for stuff and how it affects patients. It's academically curious to me, but it came from my own patients. When I was a resident, I had a patient in the trauma bay screaming, saying, "Leave me alone, let me leave. I don't have health insurance. I don't want to go broke." And this was in Massachusetts. It's like, wait, no, you do have health insurance. Like, even if you don't, we will get you health insurance. But that was like what was on his mind as he's like hemorrhaging. And that was, striking to think about here. I used to live walking distance to Harborview, and I walked up on a guy who had just gotten mugged, and he's bleeding down his face, and he didn't look like he was ambulatory. And he's like, don't call an ambulance. I can't afford one. That was his concern. And I was like, well, I bet we'll be okay. And then this last is a letter that I got permission to share on Christmas, 2 days before Christmas, a couple years back. I got a letter from one of my patients asking to start a GoFundMe page for her. And I immediately called our financial counseling folks and said, if y'all are billing her for my services, please stop that and let's figure out what's going on. But these are real things that affect patients all the time. They're not surprises to anybody here, but our system's not really calibrated to think about it on the care delivery side. Again, I think I'm on the home team here, or talking to the home team here, but these are crazy ideas. Like maybe we should insure the uninsured, and maybe we should protect folks that are underinsured, and financial hardship, something we ought to maybe do something about, and realizing that this actually is a solvable problem. It's not just like, well, things are expensive and that's just the way it is. It's a uniquely American problem. Some of these things exist around the world, but some of them don't. And so I just will go through sort of how I came to think about some of this stuff and learn about it. So 30 years ago, paper in the New England Journal says, hey, what do you know? If you're uninsured, you're 1.5 times higher to have a ruptured appendix if you have appendicitis. And that got me thinking, or not at that time, but you think, okay, well, why, they don't have insurance, or they don't have, maybe it's just they're poor. Maybe it's just they're low income, low education, etc. But Medicaid patients who by definition have to be low income, they also had a 1.5 times higher rate of ruptured appendix, and they do have health insurance, and they actually don't have much cost sharing. And so it got me thinking maybe some of the data around insurance and outcomes is really just a marker for maybe you're just sicker patients. Maybe it's not actually about the insurance product itself. And it's hard to do randomized studies on insurance policy. But right when I was getting that MPH that Hugh mentioned was when we had the greatest change in the uninsured rate in like 50 years. And it was right after the dependent coverage provision that let young adults stay on their parents' insurance and Medicaid eligibility expansion. So I said, well, what if we study these dynamic changes in insurance and not just say, oh, let's look at an association, but let's see what happens when it changes. And that was heading right into my MPH when those data were finally coming out. So kind of my first foray into health services research was really trying to understand what are the implications of 20 million fewer people being uninsured. Now, sadly, if you take this out 10 years, the curve is going back up, and that's a different problem. But at the time, it seemed like a ripe area for study. And so, unsurprisingly, but now in a more robust way, we were able to study gaining insurance and what happens. And it turns out we looked at the dependent coverage provision, and we found that when the uninsured rate went down among young adults, then the perforated appendix rate went down. And people just older than them that couldn't get the policy, uninsured rate didn't change, nor did the perforated appendix rate change. Same thing, we looked at this with Medicaid expansion. Unsurprisingly, Medicaid expansion state, uninsured rate goes down, so does complex presentation. Aging into Medicare, we looked at when you go from 64 to 65, there's a 10% reduction in the likelihood that if you had surgery, it was for an emergency indication just because you had a birthday. Probably a little more than just having a birthday. And then we said, well, is it really because they it was an affordability problem. It turns out there's a lot of studies that ask people, do you have problems affording healthcare? Did you delay care because you couldn't afford it? National Health Interview Survey, Behavioral Risk Factor Survey. And some of this was my work. Some of this was my friends that I learned a lot from. Ben Summers, really smart guy. And across the board, all these same policies, as uninsured rate goes down, people are saying, yes, I didn't delay care because I couldn't afford it. That's not happening as much now that I have insurance. So again, the idea was kind of a fun time to be able to study these concepts because it's just showing us what we think it would be there in this association, but there's some kind of fancy study design ways that we can understand this a little better. I started wondering about the burden. You mentioned I lived in Rwanda for a while, and there was a lot on out-of-pocket spending, and should they cap it? Should they limit it? And I was kind of disappointed that in the US we weren't talking about that very much. And so around the world, there's a measure called catastrophic health spending, which is if your out-of-pocket spending is more than 10% of your annual income, or if it's more than 40% of your income after food and housing. And they measure this literally around the world, except not in the US. It's not a number that's known in America. Meanwhile, it's measured everywhere around the world because it's not really been a priority, not something we want to think about. So we used some of that calculation and said, if you're an uninsured trauma patient and you're an uninsured emergency general surgery patient, you're in a bad way. 70% of these folks, a single hospital admission, this is supposed to be summed up over a whole year, but a single hospital admission, the out-of-pocket spending they have would be, put them in this global health definition of catastrophic spending. So the spending can be really high. And then we looked at this actually when I was a fellow. We looked at the Harborview Trauma Registry, and we did a study that just looked at what happened due to Washington State Medicaid expansion. And we showed huge reduction in the uninsured rate, and the catastrophic spending rate for trauma patients halved, got cut in half as a result of that. And then similarly, we use one of my mentees looked at when you age into Medicare, uninsured rate goes down, so does catastrophic spending. Again, a lot of this is like, we expect this to be true, but it's good to see it in the data, good to show it in the data. It's helpful to be able to demonstrate it. We looked at what happened with the whole of the ACA for the first few years, and we saw that, 20 million fewer uninsured, but what was really amazing to see, this is like actual out-of-pocket spending that people report during surveys. 2 million fewer people in America met that threshold for catastrophic level spending. That's kind of a big deal. But what was interesting is this privately insured group is the vast majority of people with catastrophic health spending. Now, there's two reasons for that. One, public insurance schemes normally have a lot less cost sharing, period. And we'll talk about high deductible plans here in a second. The other is if you can't pay at all, if you're uninsured, then you just pay nothing because you couldn't pay it at all. But it got me moving from the concept that as we insure more people, insurance alone doesn't cut it because the cost sharing burden that you put on patients could have a real effect. So that led me down kind of rabbit hole number 2, which is, what about this underinsured bit? What can we learn about from the data about what's going on with them? And so cost sharing has real consequences, and it's been described. There's a guy named Frank Warren who's done some stuff in diabetes and cardiovascular care, but nobody's really looked at it much in surgery. And so we started taking a better look at this. Now, high deductible plans are, on the rise. They've kind of plateaued at around 30% of employer-sponsored plans, but there's plenty of employers that provide only high deductible plans. Again, these are that sort of wolf in sheep's clothing a little bit of like, hey, don't you want these low premiums? It's going to be so great. And you're like young and working age and, you're not going to have any health problems, which is all fine unless you do. So we looked at this a couple years ago. We took an employer-sponsored insurance database that has all the medical claims from some large employers. And we looked at people that were in high deductible plans versus not high deductible plans. And then we looked for measures of delayed presentation. So if you had appendicitis, was it ruptured? If you had diverticulitis, was it ruptured? Cholecystitis, were you sick with it? Intestinal obstruction, did you have peritonitis? Were things worse off? And this is what we know to be true. High deductible plans, they're younger, they're healthier, they're wealthier, they're highly educated. This is who signs up for high deductible health plans because they're the young invincibles. They don't need anything more than that. And despite them having a better health profile across the board, they had a 34%, about a third higher incidence of having complex presentation. So you wouldn't expect that younger and healthier people to be more likely to have worse presentation for these emergency surgical conditions. And this was kind of true across the board. Every way we looked at it, it wasn't just the young, it wasn't just, one race or sex or whatever. And then when we looked at who's actually getting these crazy high out-of-pocket bills, it's the people in high deductible plans, the dark blue. And it's really a problem of lower income folks. So this is why when you talk to a room full of surgeons, they say, no, high deductible plans are fine because nobody who makes $100,000 a year, no matter what happened to them, had a bill that was so high that it bothered them. And so, again, what's interesting about this approach is it starts showing that the design of your health insurance can affect your clinical presentation. And this is among wealthy, educated, high-income folks, or not high-income folks, but sort of that working middle income, or maybe the ALICE folks, right? Asset limited income constrained employed folks. And so then some other friends looked at similar things, and they looked at a different database, or they looked at hernia. And every time people have looked at it in surgery, if you're in a high deductible plan, so you have more cost sharing and you know about it because you enrolled that way, you're more likely to be younger and healthier and wealthier. And when you show up for emergency surgery, you're more likely to show up with more advanced disease, which seems like it shouldn't be the case. So, all this falls in the category of not terribly surprising, but it's there in the data. And like all of these studies came from medical data, came from claims data, came from large research, large databases. And what it shows is when you expanded insurance coverage, there were fewer delays in seeking care. When you expanded insurance coverage, the disease at presentation was less severe. When you expand insurance coverage, the financial risk improves. And yet, when you do have insurance, but your cost sharing is too high, then you're more likely, it kind of undoes all those things that we think we're helping folks with. So while it's important to expand insurance coverage, this shows that the design, even when you do have coverage, can still result in affordability-related delays. And so then it got me thinking, okay, that's kind of on the front end before you even engage with the healthcare system. That's sort of what you're thinking about your financial risk. What happens like when you actually come to the reality of having an emergency, of having a trauma, of needing emergency laparotomy or something like that? And so that is when I started learning about this concept of financial toxicity that the oncology community talks about. So they talk about financial toxicity. They talk about, chemotoxicity, radiation toxicity, and financial toxicity is this iatrogenic side effect of having cancer and the care you receive for cancer. So we applied this for the first time, I think, into the trauma community and said, look, this is how we normally think of it. You have this traumatic injury and you have some post-acute physical health needs and some post-acute mental health needs. And those of us that take care of these patients know that this is kind of the chronic disease of trauma. Is like there was the acute event, but it's all the downstream sequelae that change your life forever. But what's happening under the hood that we haven't really studied or evaluated very well is a whole lot more. So you have these medical bills you weren't expecting, and you got to pay out of pocket, depending on your insurance, various degrees. Maybe because of your physical and mental health needs, you can't go back to work, and so now your income goes down. And so you have a lower income and more bills, and then now you have unpaid medical debt, and that gets sent to collections agencies. Well, now you're making choices between, am I going to pay off my medical bills, or am I going to pay for heat or pay for food? And then that leads to a lot of stress, and then you're supposed to get your follow-up care and you already can't afford it. And so now you're delaying the follow-up care you need, or you're skipping the care that you need, and that leads to worse outcomes. And so it's there. If you talk to patients, they tell you all about it. If you've been a patient, you know the reality of it. But our system's not calibrated to measure it, to see who it's affecting, how it affects them, what are the actual ramifications of whether or not this is even happening. So that's what my got a K08 from ARC to study this exact topic, to start talking to patients and asking them, how does this actually play out? This is just a model. Is it real? And turns out me and a handful of other people have been trying to study this. And actually, Nina Clark, one of our Harborview residents, just won the Resident Research Award at AAST this past year on a paper that used national survey data. It showed 40% of injured patients are reporting this kind of financial hardship. Single center studies, it's in the 40s to 80s. It's like half or the majority of patients when you actually ask them. And this concept, these four colored lines, is this concept of who can you move the needle on. So if having a lot of financial hardship is bad, that red line at the top, those are folks that are in a bad way before they get injured. They stay in a bad way, and it's going to take big changes. The green line at the bottom, those are folks that are financially robust and resilient, and they're fine, and they get injured or whatever happens to them, but they stay fine. It's these two lines in the middle that take a hit early on, and the question is, can we get them back to a financially solvent place, or is it just this runaway train that leads to the delayed care and the worse outcomes? And we're still kind of understanding this as it is right now. Unsurprisingly, if you report any of these financial toxicity elements, that you have debt, that you lost income, that you can't pay for your food or housing, or that you delayed care because it's unaffordable, then any health measure we look at is worse. So all the dark blue bars, those are people with these financial toxicity things on surveys, and their self-reported health is worse. This health-related quality of life tool, whenever we measure that, it's worse. And it's each of them. So it's not just one of them, that we're trying to understand like which of the pieces are actually at play here. But the worst one is always when they say, yeah, I'm not getting the care that I need because I can't afford it. And that's the most direct link to what's keeping our patients from recovering. Then this is just to show there's this like beautiful monotonic stair step. I mean, beautifully tragic, that as you add these things up, did you have none of these elements? Did you have one of them, two, three, four? And we're trying to tease out what matters the most, and it turns out they all kind of matter. And as the burden increases, the likelihood that you say, I have problems with any of these things, goes up across the board. So it's just showing that there's a robust relationship. Again, not that surprising, but not well measured. There's a robust relationship between the financial strain people feel after they have been injured, after they leave the hospital, and what their long-term health outcomes are like. So while there's been now a handful, probably about a half a dozen studies have shown this independent association between having some degree of this financial toxicity or financial hardship and physical health, anxiety, depression, quality of life. What Nina's study looked at is if you have problems with bills, you're 3 times more likely to delay care because you can't afford it. That makes sense, but again, it's important to quantify it. But then the next piece showed that if you skip care because of cost, then you're 1.5 times more likely to report poor mental health and poor physical health. And so it doesn't prove that this is the link, but this is the data I have to use to try to get people to give us funding to try to study it, an intervention to fix it. Because they're like, well, this is just poor people, and you can't fix that. And so we're trying to say, no, we need to do intervention studies to show if we can move the needle on financial toxicity, can we then move the needle on health outcomes? And this would be a causal pathway that we would try to convince a funder to try to do. So the good news is the trauma surgery community is embracing this a little bit. We've published a couple sort of review articles out there. We've given a national grand rounds. We're starting to get more and more centers to start tracking these. We're doing it in here at Harborview and in Wisconsin and Boston and Michigan and Stanford and Memphis and a handful more and more trauma centers. And we're trying to use the same questions so we can actually address it the same way. to say, okay, like how are we going to ask about medical debt, non-medical debt, income loss? That first figure that I showed you, it's kind of coming to reality. It's kind of an exciting time to say, you got to measure what matters. You can't fix what you don't measure. Let's try to measure it the same way in different environments and try to understand that better. So this is happening sort of in real time, like month to month right now. And so it's not just a handful of us. PCORI is a place that I hope they have a little more. They're less likely to get their funding canceled because the way they're structured, the way their budget is structured. I gave a pitch to PCORI on this, and I was like, just so you know, you've been talking about this for a long time. So they call this terrible acronym PCBEOs. So patient-centered burdens and economic outcomes, but it's the same concept. And they did this big thing with Rand and had a whole episode of medical care, what am I trying to say? A whole issue of medical care on it. And so, point is, funders, people that say we care about patients' long-term outcomes, we care about things that matter to patients. Of course, patients care about this, but like, it's not really what research. It's not. Is it real research? That's what I get from people. Are you really doing medical research? It's like, well, it matters to patients, and it keeps them from having the health outcomes they need. So I think so. So as we're getting more and more data, there's actually NCI funded, so National Cancer Institute is funding a trial here at UW by Veena Shankaran is the PI on the study, where they're doing remote financial counseling and essentially just using the tools that already exist. And so we're hoping to do the same thing using Harborview data. I'm working on a grant right now. We're going to try to pitch to PCORI. And I'm working on a letter of intent. So I'll let you know if we can move from description to understanding it a little better to intervening on it to actually improving patient outcomes. That's what we're trying to do next. Here's a little preview of unpublished stuff, and I promise I'm coming towards the end here. This is what the other half of my K grant was on at Michigan. So we took the trauma registry at Michigan and we sort of were able to, in a de-identified way, link it to credit report data every quarter. And then people got injured at some point in that yellow bar there, but that meant we had a lot of credit data before and after their injury. And so, again, even though it's not surprising to say, hey, you got injured, do you have problems with bills? And they say yes, it's probably due to their injury. But it doesn't prove causality. What you really need to know is data before and data after. Turns out it's hard to interview trauma patients before they get injured. So patient-reported outcomes is not, you do. My wife works in the ED and she has a lot of continuity of care with her patients nonetheless. But this was a way to kind of get around that by getting these financial outcomes that show up on credit reports and looking at them sort of this longitudinal way. And again, unsurprisingly, medical debt goes up by hundreds of dollars. This is what you call the unconditional means. There's a ton of zeros in here. If you look at how much it actually goes up for people for whom medical debt went up, it's about 3 times this. But unsurprisingly, when you get injured, you can't send bills or it used to be, now you can't. This is changing. Policy is happening like right now, month to month changes. But used to be you couldn't send it to medical collections, medical bills or collections for 6 months. And our data showed just that it's quiet for 6 months and then it starts popping up once the hospitals start sending bills to collections. And then interestingly, we also saw bankruptcy go up as well. And bankruptcy is a little more complicated and there's quite a debate in the literature, but I'm with Himmelstein on this one. And these data seem to support that too. So we're under review. We'll see what happens with this. We kind of looked at it by subgroup, and this fits with some of the patterns you'd expect, but there's some interesting differences. So, when we looked at it by race of the proportion of people with medical debt before and after, it's higher among Black patients and Hispanic patients, but the magnitude is pretty similar, actually. And so the delta isn't a lot bigger by race. It's just that they start a different place. Meanwhile, if you look at the uninsured, that's a huge arrow. So this is the kind of before to after change. The length of the arrow is how big the difference was before and after. And where they line up tells you. What I want you to look at, though, is Medicaid. it didn't move hardly at all. That's like one of the smallest arrows on the list. And what's funny about Medicaid and a trauma registry is that these people probably came in uninsured and got retroactively enrolled in Medicaid, and we can't pick that up in the registry. So that might be why it's so high. It's like higher than the uninsured at baseline, but it doesn't hardly budge at all. And so this just shows that if you can enroll people in Medicaid, if your state is a state that does that, that can be a life-altering thing for those patients. Meanwhile, privately insured people have a pretty big increase. And then again, it goes by income. Unsurprisingly, if you make more than $100,000, it's not really your issue. And then the age changes. Two things probably going on here. One is, do you have assets already that you've saved up that if you can spend down your assets as opposed to taking on debt? And the other is, do you move your body to make income on a month-to-month basis that is what your household is dependent on? And if you get injured, you stop doing that. So income loss is less of a concern among folks that, when the proportion of retirees goes up a little bit. We just did it. This is like this week. So this is hot off the presses. We did a hospital level analysis and we said, okay, we have these 31 trauma centers. What's the average amount of medical debt that each of these trauma centers increases because you got injured? A patient's at that trauma center. And so over here on the left, these patients, on average, their medical debt went up by $80. And over here on the right, these patients on average went up by $900. And we said, that's kind of weird. There's like a tenfold variation, but maybe it's just difference in patients and income and insurance. And one trauma center just takes care of a bunch of uninsured, low-income folks, and one takes care of a bunch of wealthy, folks with good financial risk protection. So we did this whole mixed effects, random effects model, and I could tell you the Greek equation, but I'll spare you. But the bottom line is this line that goes across the middle is zero variation at the hospital level that's not explained by the patient's makeup. And what you see is like most hospitals are in the middle. It's like, yeah, it's probably driven by the differences in the patients. That's what's actually driving this. But the ones way on the right, it's actually not that. So their random effects are like $200, $300, $400, $500 difference that is beyond what you would expect based on the patients. And so this is kind of fancy statistical modeling to show that these are the bad actors, actually. Like these are the hospitals that, based on what we know about the patients, based on the income and the injury and the insurance and all the stuff that we know about the patient, these bills are higher than they should be. And unsurprisingly, they're the hospitals with the highest bills total. And so that just shows that a lot of this is iatrogenic, and it's these hospitals are going after folks. And it fits with what sort of makes the news, right? And I'm not calling out any specific hospital, but there's all these, exposés that show up that show hospitals suing patients and they like get their own collections agency, so then they sell it to themselves and then they can go after, because they're like, we're not going after patients, but just the collections agency is. Now, we might own the collections agency and make money from it, but don't worry, it's not us. It makes the news, but then people like what we're trying to do, it's in the peer-reviewed literature as well. And the fact that we saw that about like 10 to 15% of hospitals were the bad actors fits with sort of what's out there. That they look, and it's about 25% of hospitals in Wisconsin over a couple of years were responsible for about 70% of lawsuits suing patients. And so like the big take home here is there are bad actors. It's not everywhere, but some hospitals like lean really hard into this and lean really heavy into this. And pretty much every time they get called out, they stop doing it. And they're like, oh, I don't know how that happened. Don't mind us. And so peer pressure really does something about it. But, this is, God bless America, this is a very American problem. We got 100 million people holding medical debt in this country. It's thought that, maybe more than half of bankruptcies are related to medical debt and the amount of medical debt. So said another way, our current health system is funded by putting $200 billion of non-payable bills on the back of the sick and injured and grieving individuals in our country. I just think maybe there's a better way that we could fund it. It seems like that's not really the best design. So This is where this, frankly, can be the last slide. We can think of dozens of solutions to this. It's not just one solution. And when people are always, well, like, what do we do about this? Who's to blame? Who's at fault? What can we do? Because we're showing that affordability concerns mean people show up later than they should, and they have worse health as a result of it. And then even when they do get the care, affordability concerns keep them from getting the care that they need long term, and that they're right to be concerned because hospitals are going after them and they're suing them and they got debt sent to collection. So they're not wrong to have these concerns. And so, this is not an exhaustive list, but what can states do? Well, expanding Medicaid eligibility was a choice. Every state that put it on the ballot passed it. The only states that didn't are states that prevented it from going onto the ballot. Looking at you, Florida, my birth state that I didn't want to tell you. Some states have some charity funds. So this funny thing that collections agencies buy debt from hospitals for pennies on the dollar. So now there are these like non-for-profits that are going after, they're like, well, we'll buy debt for pennies on the dollar and forgive it. So we can forgive millions of dollars of debt for a couple $1,000s. And so that's not really an ideal way to do it. But I think it was Maryland. Some states have done this. They've like used state funds to forgive debt. But sadly, it's going through the whole system. But I don't know, maybe you shouldn't let hospitals sue patients for unpaid bills. Or at least make it illegal to not to deny care because patients don't have bills. These are things that were supposed to be in the ACA, but they don't have teeth. There's no enforcement. There's nobody to check, to measure, to do anything about it. Federally, I would love to see that we don't allow the selling of medical debt. And the Biden administration did put some limits on what can happen with credit agencies, but it turns out credit agencies were smart. So the big three, Experian, TransUnion, and oh, come on, who am I not thinking of? The third one. It'll come to me. FICO, yeah. So the big three said, yeah, we're actually gonna like delay it for a year, and we're not gonna do anything less than $500. And now some of them are saying they're not gonna put on credit reports at all. Why? Because it didn't predict who defaulted on loans. Because it's such a ubiquitous problem. Like if you default on your car loan or your home loan, like you probably have some bad decision-making ability because like you knew how much that was going to cost. That one's not a surprise. But the surprise nature of medical bills means it didn't predict what the credit scores were designed to predict. So they, got the good, look in the media by saying, oh, yeah, we're going to take this off credit score. So it just means all that research I did, you couldn't do it in the future because they're not going to show up. Now, the debt's still there. It doesn't make the debt go away. It just means it's not on their credit reports. But we could incentivize hospitals to behave in patients' best interest. Surprise billing, the No Surprises Act was pretty good, but there's some big gaps that remain around what can be out of network and a surprise, and maybe a public option. I don't know if this group would know anything about how that could be structured or what that would look like. Hospitals just use the stuff we already know. Hospitals know how much people make. They get that information. They could automatically enroll them. I think some hospitals, I think Harbor's pretty good at this compared to others, but they could just use, instead of making the patients jump through the hoops, it's just like the people that try to get Medicaid enrollment down by making it hard. A lot of hospitals just make it hard. Out-of-pocket limits on emergency care make a lot of sense to me. To say, yeah, we're only gonna, we're gonna limit it at some point. I think payers, to me, this means-based deductible is like like something that could pass in like any policy environment. Like your employer knows how much you make because they give you your income. And so it would be really easy to say your deductible is capped at some proportion of your income. The fact that the janitor of an organization and the CEO of that organization, if they're on the same health insurance plan, have the exact same deductible is just bonkers to me. It makes just no sense at all. And it's kind of one that could be built in and be viewed as, I don't know, I think that one to me has legs. And in making real emergency care pre-deductible, it's kind of a no-brainer. Like the whole reason of deductibles and cost sharing is to prevent overuse of healthcare. And so if you like get hit by a car and are, intubated in the field, you're not like going to overuse that crash cranie or that exploratory laparotomy based on how much cost sharing you have. So it's the most inelastic care. Now there are concerns about like, oh, don't overuse the ED. So you could put some limits on it. Point is, it's an easy thing to do. You just have to think about it a little bit. And employers, employers don't want to lose employees. It costs money to replace an employee. And I think there's a way to highlight like, hey, if we can prevent some of this, keep people in the workforce, keep people going with sort of short-term assistance or sort of like gap disability coverage. Essentially, don't turn off the faucet if you're in the process of recovery. I think there's an argument to be made to employers that there's some losses you have due to churn that if you support your own people, maybe there's some ways around that. And defaulting to high deductible plans, like many employers do, I think is just a setup in the wrong direction. So the rest of it is just that states are doing this. And this is the, Brandeis quote of states are the, laboratories of democracy. And so I think there's a lot happening around medical debt in different states, and it's been a pretty hot sort of 2 years on the topic. If you go to the Commonwealth Fund, they'll show you all these different states. Washington shows pretty well on this of limits to credit reporting, limits on foreclosures and liens, limits on wage garnishment, preconditions before bills can be sent to collection. So there's a lot of different things happening out there. And again, I think this is all going to be state policy. I mean, my only hope for the next 4 years really is that there's some states that lead the way. But, the Affordable Care Act was like sort of state policy that was trialed and tested and became, made its way into a federal audience. And so I think that's, if you ask me what way are we going to get, it's probably going to be more states strengthen these protections. And then there's advocacy groups doing it. I'm trying to learn about them, get to know them better, but these are kind of groups that are doing specific stuff on medical debt. This RIP medical debt, literally you give them money, they buy debt and forgive it. Like it's kind of a hilariously tragic and very American charity. It doesn't exist in other countries. So this affects our patients, and ultimately, like it's an erosion of trust in the system. And so I think it's important that we, as the healthcare system, are a part of calling it out, calling out bad players, like private equity. This stuff's going to be through the roof. A lot of the business models on that. Air ambulance is a huge problem. Some air ambulances like Airlift Northwest are great. They don't sue anybody. If you don't have insurance, they don't bill you because they get funding from the state. Meanwhile, their other air ambulance, their whole business model is on always out of network billing and suing the people that they fly. Like that's how they're structured. And there's kind of they know who each other are and they don't like each other. I'm learning as I'm dipping my toes into it. But whenever I'm talking to other docs, I say, learn as much as you can about about these issues. And then when I'm talking to my trainees about research, is like let's keep learning as much as we can on a research side. And then wherever you're working, learn how your hospital works. Don't be scared to talk to your patients about it. But ultimately, this is all going to be upstream policy stuff in addition to kind of bolstering what's here and now. So sorry, that ended up being longer, but I get a little bit fired up.
That's why we invited you, John, because you do get fired up. Bless your heart. Any questions from anybody? Ronnie?
I was really glad to see you point out some of these other factors. We certainly can target co-payments as being an issue, and we can certainly blame things on patients, but it's really important as providers or as part of monitoring the healthcare system that we realize all these other factors you were describing. Patients don't know the mental health damage that's going to occur. We would see trauma patients at Harborview who, firefighters who, were injured, but we didn't, it took years to realize that they too, they had seen people die, and then the firefighter next to him die, or the person in the fire that they were trying to rescue. And that had such a traumatic injury. It's so hard to separate that out. It's important. I really was glad to hear you talking about the importance of identifying each of those issues, but the financial burden can really build on that and destroy people. So thanks for being a part of that system that's identifying that issue. It was so hard dealing with people one on one when you knew you could see in their eyes that something else is going on here. I can give you physical therapy or another corrective surgery or medication. I was a pharmacist, but that's not answering the financial and the emotional stuff that are so hard to pull out. So thanks for recognizing that. I think that's something we need to really pay more attention to.
No, I love that observation. I love that parallel because it's one I use a lot. Now that every trauma center in America has to do this thing called Esper, screening, brief intervention, referral for treatment, because of Harborview. It was like
Right.
literally the data from Harborview that showed like, hey, this crazy idea of asking people like, hey, you want to like talk about this? Because like maybe now's like the time is like it worked. It was like that simple. And honestly, I use Esper as an example of saying, like, I think that's actually there's big policy solutions, but what hospitals can do is like, hey, are you struggling with this? Like, can we like actually help you and not just wait till people write handwritten letters saying can you help me start a GoFundMe? And so I think there's a lot to like this insidious threat to our patients' well-being. People want to say, oh, that's not our problem, but like mental health is our problem. And things like addiction is our problem too, if we want our patients to get good outcomes. So that's often how I find that I'm framing this of like, don't you want to have your patients have the best possible outcomes? And like everybody says, oh yes, of course. And I'm like, well, if I could tell you this hidden threat that's keeping them from having good outcomes, wouldn't you want to do something? Oh yeah, let's like do it. And then they're like, oh well, that's just, socialist, right?
That's great, John. That follows in the model that Larry Genelello with alcohol counseling before the patient was discharged at Harborview set a national trend and it became national policy. So that's fantastic. You followed in the steps of your forefathers and brought that to national attention in another whole sphere that was, the thing that should not be spoken. Cello?
What was that scale called? And is it like the ACE scale that we use in education? The childhood adverse events scale? Is it like that?
Where I was showing the financial, yeah, that one's called Esper. It's a screening, brief intervention and referral for treatment. It's on alcohol recidivism and injury.
Okay. And it must be like the ACE, right? ACE, the adverse childhood.
It is similar. It's mostly saying like, hey, you want some help with this? Like you're in the hospital because of your alcohol. You want to talk to somebody about it. And
Cool.
it's like
Okay.
kind of takes the teachable moment concept and made
Right.
it feel.
Okay, thank you. Because I wasn't a doctor, I was like,
Oh,
oh, okay. So now I have two other questions. My first question is about this idea of moral hazard. When I was trying to get access to some papers that disprove this concept of moral hazard, I did come across a couple of really, really good papers from Roberts, 2021, which was excellent, that showed that patients who have diabetes and who have suffer really, really severe effects don't go to the doctors, and they would be the ones that you would think would be overusing the most because the impact of not going to the doctor is like losing a foot, right? So I would be really interested to learn from you where we can do more research about moral hazard because we're having single payer models put forth that include copays, and I am really against copays.
it is so fascinating how like so Mark Pauly was like the guy out of Chicago that came up with the moral hazard phrase in
Of
the
course it was.
50s. And I actually wrote a viewpoint on one of these high deductible plans. I was like, the hazards of cost sharing. It's like, you want to talk about hazard, let's talk about the hazard of cost sharing. And like, these patients have worse outcomes and all. And so my wife is a lot smarter than me. She got her PhD in health policy at Harvard, and Joe Newhouse was one of her PhD advisors, and he was like did the RAND health insurance experiment. And so that is like one of the few randomized controlled trials in healthcare in health insurance, and it was various amounts of copays from zero to small amount to slightly higher amount. And that's the study that proved moral hazard. And the data are terrible. The data are like vision at 20 feet and diastolic blood pressure and all this that are based on cost sharing differences that are like really small. And so some of this high deductible health plan, some of these studies are probably the best things out there that keep showing that it's actually more of a health hazard than the cost moral hazard. And a guy named Frank Warham, Wharam, his stuff, he got his hands on database that has employers that forced their employees into a high deductible plan. So that's his brilliant natural experiment, because the challenge with the self-selection is like, you know something about your health, and you might know something about your health that year that you change your enrollment that's never going to show up in the data. But if you were just forced into it, everybody that works in your company was forced into it. And so he does these nice natural experiments.
Right.
It shows time and time again exactly what you're worried about, is that there are negative health consequences to these seemingly small changes. And so there's just no elasticity. Like, there's no elasticity for some of these emergencies. And so this notion that, we're going to reduce overuse, I think that we're not going to make it all go away. But to me, the way to attack cost sharing is start with means-based deductibles, because there's other things in American society that are like, our tax code, for all its imperfections, like people kind of get this concept of like how much you have can like be like how much you put forth can be linked to your income. People sort of embrace that in other economic domains. So I think means-based deductibles is one. And then the other is just carving out things that there's like really no moral hazard. In the ACA, they made a lot of screening pre-deductible, but then if you needed treatment once you got diagnosed, then it wasn't anymore. So it was sort of the like halfway there.
I know that one. So now can I ask one other follow-up question?
Quickly, yes, please.
Okay. So I was struck as a single payer advocate that you did not think about single payer as being a solution. And I would encourage you to really look at Hammerstein and other papers that have delved into the cost savings that come with a single payer universal health program, as well as other countries that have much lower costs of treatment and much better outcomes. And I'm shutting up now.
Yeah, I'm all for it. I just think this is the only crowd that is wants to
Oh, okay. I wasn't sure if you were.
Yeah,
Okay.
yeah. But I'm with you.
Yeah, I just plowed through Gerald Friedman's analysis of Washington State with the single payer mechanism, which, John, I think maybe you could understand. I'm still my head spinning. David, you had a question?
First of all, I really love this presentation. And I don't know if you have your presentation on film online that people can get at it, but going to do that with your presentation. And if we could have your slides too, that would be wonderful. There's so much information there that whizzed by because you talk so rapidly and so well. I want to go slowly, and we'll be able to do that with a video that'll go on our YouTube site. So thanks for that. First, I wanted to say, I think conflating moral hazard, Elizabeth, with moral injury, those terms are out there, and I think people are confused. What are you talking about? Moral hazard, moral injury. I think moral hazard's got to do with overprescribing stuff to make more money, right? But moral injury is the withholding care that needs to be done. That's something that PNHP is doing research on now. I talked to Pramila. She agreed to have a meeting with myself, Hugh, and I also mentioned you as a fabulous new organizer in this area. So we'll be meeting with Pramila, I don't know when, but sometime in the near future to talk about this moral injury survey that PNHP is doing.
That was so good.
And so we're going to ask her if there's any way that she could help us get in contact with all the physicians and providers that, love her so that they can do the moral injury survey.
Can you just clarify about the moral hazard? I understand about the moral injury, but I don't think I know about moral hazard.
Yeah, so I'll just tell you my quick interpretation of it is it's the tragedy of the commons. So if you're not on the hook for what you consume, then you may overconsume. And so it's like if you don't pay anything for your health care and you have a headache and you could get an MRI or take a Tylenol, you'd be like, well, it's free for me, so I might as well get the MRI. And the notion is that as more of the burden of so that would be the hazard that you would just overconsume because it doesn't affect you.
Oh, I
And
see.
so as you have to pay more for the care that you use, then you're going to restrict care because you're having to pay more for it. But the theory behind it is, but you're not going to restrict care to the point that it negatively impacts your health. Based on the Rand Health experiment from 3 states in the 1970s, where we were talking about dollar amounts in the dozens of dollars. So, like, that's why I think it maybe doesn't apply. But it is like canon in health economics literature. Like, it's like the first day of class. It's such an ingrained concept.
Questions when you were doing your look at high deductible plans and how this adversely affected care, you weren't talking about Medicare Part A, Part B, and I have, a Medigap plan, with not Medicare Advantage, it's traditional Medicare, but you really need a Medigap plan to cover the vision, hearing, dental, and drugs and stuff. So,
And the deductibles.
Yeah, and I have the high deductible plan. Did you include looking at Medicare people in that survey?
Yeah, that's great. And, Medicare claims data, like a bulk of health services research data is based on Medicare claims, but it's normally just Part A and B claims. The ability to figure out who's enrolled in what is actually much harder because it's mostly like how's the whole health system work. That specific study and those that have come like it are actually from claims databases that are linked to employer-sponsored insurance plans. So it's not Medicare, they're not even in there. And so it's just the private plans that, big employers like, GE, Amazon, Walmart, like they would be in these. Optum has one, and then this other one that's run by IBM called Market Scan. But there are these two big employer-sponsored insurance plans or insurance claims databases. But no, we didn't look at Medicare. I don't think people have looked at Medicare quite as robustly because I don't think it's as easy to tease out the deductibles that people are like the insurance benefit design piece. The benefit design part is harder to tease out. There is something called the health and retirement study that would have a lot more detail, but the sample size is really small.
Mm-hmm. Yeah, the other one was about in our state. I think our Attorney General Ferguson, well, he was who's now our governor. I think he sued the Providence system for, and you got was it 400,000 or 4 million or something. He sued them for. Was it not providing the charity care that they were supposed to, or not having signs that people could apply for charity care? What was it exactly there?
So I don't know the specific case. If somebody does, please fill it in. But I'll tell you the ACA did. I'm fascinated to hear about this. I want to learn more about it because the ACA did say you have to. So they have these extreme collections practices that they didn't totally outlaw, but they said you shouldn't do. And then they said you have to tell patients about your like you have to offer it to everybody.
Yeah.
But there's nothing about what happens if you don't, and there's no regulation agency that's going to check if people do. And so you mentioned Stevie Woolander. There's a really nice quick one-page viewpoint in New England Journal on it's like Upall is the first author, but it's like Woolander, Himmelstein, and Upall, and it's about uh, how to tackle medical debt. And one of the things they have in there is like, why don't we do the stuff that we say already that you're supposed to do? And that's just one of them. And a similar parallel at the state level, not the hospital level, is the presumptive enrollment in Medicaid. So California is one of the leaders in this. I would imagine Washington's pretty good too because our numbers are pretty good. Of essentially, it's like, do we assume that you're in and then like we get you enrolled and then we like kind of figure out the details later, or do we like make the bar really high to get in and to stay in? In California's the presumptive enrollment stuff has shown to be really successful, and hospitals get paid more. And so that's why I'm always like try to show that there's a lot of different agents in this that could have a role, and although single payer makes it a lot simpler, I think it's finding like what angle people would be motivated by, and how to address some of their pain points while also trying to do what's right for the patient.
I think the Providence deal was that they were not advising people up front as soon as they discovered that they were eligible for charity care.
Mhm.
And a lot of those people ended up going to collections and being, really financially burdened by the lack of that upfront acknowledgement by Providence. And they whacked them big. I mean, it was top of the fold New York Times when that came out.
Mm.
It was pretty amazing.
Was it 4
Got it.
million? I think they're supposed to have in their emergency room a sign that says if you can't pay for it, here's where to go to, and we can maybe help you out, something like that. Like
Yeah.
Providence didn't have that. And
No.
Providence is a big system, they got quite a few hospitals.
The payout was pretty incredible. It was almost 160 million.
What?
The payout was? Yeah.
Yeah.
Bob Ferguson was behind that.
I just wanted to add one thing about the terminology of moral hazard, which is that people who oppose single payer have said it will be, you'll increase the number of people who get care, whether it's, what level it is, and that is a cost. That is a moral hazard. More people will come in to see the provider. But there's clear data around the world showing that if you provide that primary care, then you're less likely to have more advanced cases and you actually significant savings. So moral hazard of creating a single payer system would be, yeah, people will come to see more people will come to see their providers, but you'll have the care that you need. You'll prevent the complications, and treating one person for end-stage renal disease can pay for 1 million people getting treatment for hypertension. So we need that. That's a good, moral dilemma, and people do call that a hazard as well. I find that in the terms of, in the words of many people that oppose single payer, I think it's something we should keep as healthcare advocates. We should keep that particular definition of moral hazard in our minds.
Yeah. And in that, on the sidebar of David's website for the state chapter, there's a reference to Gerald Friedman's analysis for the Washington State Health Security Trust. And he addresses that, Ronnie, and shows and references the data against that moral hazard argument really well.
And it's all around the world. You can find data in Europe and Asia and Africa if they could afford to create the data, that it's clear.
It's a version of the slippery slope. Like, oh, I don't like that thing. You know, it's a slippery slope, and like it's a conversation ender. Like I've never heard somebody talk about it to like really flesh out like the right best way, but then instead they pull it out as like, I just want to stop this right here.
It's the old welfare Cadillac argument
Yeah,
of
yeah,
yesterdecade.
right. Yeah, which is now today. It's back. It's
Yeah.
what's old is new again.
Yes.
Thank you, Elon Musk. Thank you all for the discussion and for the time and the opportunity, and I really appreciate the chance to visit with y'all tonight.
Thank you.
John, thanks so much. We
Busy,
appreciate it. Keep up the good work down there, buddy.
Yeah.
So, John, you've got 15, 20, 30 more years to work. Are you going to be able to hang in there?
Yeah, well, I don't know if I can do what my predecessors, like the good Dr. Foy, did, taking all that call forever. But yeah, who knows what lies ahead. But I'm enjoying what I'm doing right now. So
Good for you.
So, John, you can somehow get your slides to me and I can make them available on our website.
yeah, I just need to doctor a couple things out of it. But yeah, I just want to make sure the references and stuff are right. Some of this was kind of slapped together, but yeah, I'll get you a cleaned up version.
Oh, it's really a fabulous slideshow. I learned a lot from it.
Yeah, awesome. Well, thank you again, everybody,
Thank you.
for the time and attention and discussion.
Thanks a lot, John.
All right.
Okay.
Thank you so much. It was excellent. I learned a
Here
ton.
we'll go our usual countdown, 5, 4, 3, 2, 1. Click.
3, 2, 1.
David, it was so
5,
beautiful
4,
to see your
3,
background
2,
of all your
1.
art.
And bye-bye.
Bye. Good night, everyone.